What is the mantra that every prescribing psychiatrist should have when encountering a patient?
How can I see this patient not as a machine that needs to be fixed, but as a wayfarer who needs accompaniment?
Love it.
And what's needed right now for the journey?
Oh, that is so good, Warren. This is why I emailed you a year and a half ago. That is it. I love it. That is it. Good morning and good afternoon to you, Dr. Warren Kinghorn, and you are in North Carolina.
That's right. Thanks, Suzanne, for having me on. I really appreciate it.
So I read your chapter in the book Uncommon Ground, Living Faithfully in a World of Difference, which in 2024 is, I think, more meaningful, about how we can live harmoniously with such diversity. And your chapter was The Caregiver. I love that.
Yeah.
And I emailed you because I read that chapter twice.
Yes, thank you.
Do you remember that?
I do. Yeah, thank you. And I don't think I responded very promptly, so I'm really grateful for your patience.
But let me. I went through the email. This is what I said to you. As an educator whose practice is shrouded in relationships and authentic connections, I will be honest. I wrote this, that I have come to abhor the field of psychiatry. This is like my second sentence to you in my very first connection with you, and you actually still responded to me.
Absolutely.
And because I was so taken by what you spoke about in terms of pharmacology, that's prescribing, and relationships. So thank you for getting back to me, even though I started by telling you I hated your field of work.
Yeah, I appreciated your email because a lot of times people just wouldn't bother to reach out. They wouldn't say that. And so the fact that you did meant a lot, actually.
But did I not offend you? Because I will be honest, I actually still really don't like the field of psychiatry. So what do you think about that?
Listen, I'm a psychiatrist. I believe that psychiatry can do great good, but frankly, there's things about the field of psychiatry that I don't like either, that I would critique myself. And I think actually that psychiatrists really need to be listening to people that have concerns about how we organize our work and what we do. So to me, I was like, this is fantastic. I'd love to be in conversation.
Well, I was in the middle of psychiatry. And, you know, so I told you I was at a youth psychiatric unit, and I watched kids fake becoming discombobulated, dysregulated, so that they could get more out of it. And, you know, I even talked to a kid only in the spring. I said, well, how do you feel about your time on this unit? And he said to me, I don't even remember it. And we were therapeutic because he was so medicated. He went from 25 milligrams of quetiapine, Seroquel, which knocks you out, to 250 in a 3-week period. And that was with psychiatry. So when you came along with what we're going to talk about today, it just hit me like a ton of bricks, because of this is what we need. So tell me your perspective overall of the field of psychiatry, and why did you become a psychiatrist?
Yeah. Well, a couple of maybe disclaimers to start. You were working on a unit with children and adolescents. I'm an adult psychiatrist. I don't work with kids. I'm not here to give medical recommendations specifically, or to speak about specific cases and what should have happened. But I can speak about what it's like to be a psychiatrist. I'm here in the U.S. My clinical work is in government system and the Veterans Affairs system here. I take care of military veterans, and I've had the chance through my work also, not only as a psychiatrist, but as a theologian, also to work with churches and faith communities around issues of faith and mental health more broadly. I have like maybe a little bit conflicting feelings about the work of psychiatry. On one hand, I love being a psychiatrist. I remember when I was a medical student and I was wondering whether to specialize in psychiatry or in internal medicine. I remember going and visiting an older psychiatrist who was a Jesuit priest and also had spent his life working in inpatient medical units. And I thought he'd be a good person to talk with about like whether I want to be a psychiatrist or not. And I remember going to speak with him and telling him my thoughts and what I was wondering about. And I remember he looked at me and he said, I've spent my life as a psychiatrist working in intensive care units. And I love the intensive care unit. I love like walking in the unit and seeing the ventilators and the drips and the busyness of the staff around a patient. And I love the complexity of it. But for me, to be able to walk into that unit and to be able to see this person in this bed who may or may not be able to talk to me, not just as a collection of organ systems, but as a whole person with a story and a community.
Yeah.
And then to be able to go out in the waiting room and see his or her family waiting there and to think with them about this person as a whole person with a story, that is a great privilege. And that really stuck with me. I do think it's a great privilege to be a psychiatrist and to be able to engage with my patients, not as collections of organ systems or as collections of neural networks, but as a whole person with a story and a community, and to be able to think what's needed. That's powerful. And I could talk about how psychiatry, I think, sometimes doesn't model that.
Well, I was just going to say, you're leading into what I'm going to say is you just said one word that in my time as a teacher on a psych unit that I know from at least another, not our unit, but another unit, was the word engagement, and how often my observation, at least here in BC, of our acute units, like our psych units, is somebody comes in and they had a suicide attempt or slicing themselves up and down, or they're in psychosis. And I can tell you, because I've heard on the inside of what happens on our unit, is the exact opposite of engagement, where psychiatrist comes, sees them, looks at the diagnostic and statistic manual, and it's their book, and it's this, check, check, check. Here's your diagnosis. Here's your medication. Great, you're stable.
Yeah.
Off you go, and we'll see you next week. Without the engagement that is required for not just diagnosing, but for choosing prescriptions if you're going to medicate or not. So that whole word engagement you've just said goes against the grain of everything that I have witnessed with at least adult units. Our units had engagement too, night and day.
Yeah. I mean, thank you for that witness. I think telling the story of that experience is really important. I mean, I know that there are psychiatrists out there who practice differently from what you named and mentioned, but I also think that there are incentives in our field to operate in the way that you describe. In one of my books, Wayfaring, I talk about what I call the machine metaphor of mental health care, or the machine model. And if I had to describe the way that psychiatry can work as a kind of assembly line, here's how I do it. That people come to me as patients, whether they're referred to me or they choose me, and they come to me and with what we might consider unwanted experience or behavior, or disvalued experience or behavior. I mean, things aren't going well in their life. They're feeling things they don't want to feel. They're doing things they don't want to do. And I'm trained as a physician and as a psychiatrist to say, okay, I recognize what's going on with you. You have symptoms, and that naming people's experience as symptoms then allows me then to say, well, I now recognize these as symptoms, and then I can cluster these symptoms into diagnoses. And so if you have a certain set of symptoms, I can diagnose you with major depressive disorder or bipolar 1 disorder or obsessive compulsive disorder or whatever. And then having then labeled you with a diagnosis, I can then reach in my toolbox of medications or psychotherapies and say, well, now I know what can help to treat this diagnosis, with the goal of reducing your symptoms. And then if you were to come back in, 2 weeks or 4 weeks or 6 weeks and say, hey, my symptoms are reduced, then I say, great, our treatment is working. And, I assume that you're happy, I'm happy, we can keep going like that. Of course, anything that can be applied to diagnoses to reduce symptoms can be bought or sold, whether that's a medication or whether that's a unit of time. And so then we end up with a kind of mental health economy where we're constantly marketing and trading and buying and selling technologies to reduce symptoms. And so mental health care becomes this complex practice of reducing symptoms.
Right.
And in many ways, I can celebrate that. Like if my patients come to me with really severe depression or, hallucinations or other things, I want them to be more comfortable, and I want their symptoms to go away, or at least for people to be able to live with them. But if all of mental health care is just a matter of reducing symptoms, and if anything I can use to reduce symptoms counts as good care, then there's so much that's left out of that.
Right.
Like the story that someone bears. And
well, and here's the thing about your profession, and this is not my saying this. I first heard this from Gabor Mate, and I've said this before, is your field of medicine is the only field that does not have a scan of what you're
Yeah.
diagnosing. You don't work with a brain scan for
Yeah.
ADHD or the psychosis you have in front of
Some
you.
of us would like to, but we're not there yet.
Right.
Yeah.
We're not there
Yeah.
yet. And
That's
so
right.
picture though,
Hmm.
like it's going, I've got my arm is like half 90 degrees and I go to the hospital to ER and they're like, yeah, we think it's broken without doing an x-ray or
Hmm.
searing headaches without an MRI. And so the complexities of your field are enormous when you're dealing with the diagnostic book, right? This is why I love what you're saying so much, because everything you've said, like that relational aspect and engagement we need for
Yeah.
accuracy, given you've got hands kind of tied behind your back. I felt on our unit sometimes it's a blindfold around that
Yeah.
psychiatrist throwing darts at a dartboard, hoping we get this, because it's such a crapshoot. And you don't have that scan that every other medical professional has.
Yeah. Well, yes and no. It is true that we don't have lab tests or scans that guide most of our diagnoses. There are occasionally scans and laboratory tests that can be really helpful in
Mhm.
clarifying or ruling out particular things. But I don't think that's completely unique to psychiatry. I think that even in like primary care medicine, where so many people come in with what might broadly be called either mental health problems or chronic pain uh, or problems with energy and fatigue or other things. I mean, it is true that doctors will order scans and will order lab tests, but frequently those scans and lab tests come back inconclusive or they don't show
Sure.
anything determinative. And so then the doctor isn't sitting with the patient thinking, well, what do we do now? And I think that's where it's not just psychiatry, but all of medicine, and I think all of healthcare, not just the work that physicians and prescribers do, but all of healthcare, I think, is not just a matter of kind of picking apart the machine of the human body to figure out what's broken, but it's a practice of like what happens when people come to you and things are just not going well, and how do you draw on deeper traditions of wisdom to think about like what do you need uh, for your life and what can lead to well springs of life for you. And I think that all of medicine, not just psychiatry, requires kind of practices of sitting and walking wisely with people and not actually pretending that we're ever going to have scans and lab tests that are going to do our work for us.
Good point. Yeah, no, true. That whole relational aspect is they're everything. So, okay, so I've got your
Yeah,
book here, Prescribing
yeah.
Together. I did get
Thank you.
it.
Yeah,
And I
great.
love the word together,
Hmm.
prescribing. And you've got a section, it's on page 3, prescribing happens in relationships. So I want to shift our
Yes.
dialogue now from talking about psychiatry into prescribing, because there's so many people I think that have questions about medicating, not medicating, etc. And even we know there's a trial error always of prescribing. You said that when we have relationship, prescribing is infinitely more accurate.
Yeah.
Do you want to talk about
Yeah.
all that for me? Explain that to me and what
Well,
you
I think
say in the book.
a lot of times we think in the world of medicine and maybe psychiatry that like that our job is just to basically to just match the right medication to a disorder to be able to treat symptoms. Um, but what we neglect in that is the role of the relationship that people have with those who prescribe medications to them and how important those relationships are in our healing. Part of that is because the structure of the way that we do clinical trials in psychiatry, uh, typically in a clinical trial, you'll have a group of people who've been diagnosed with a particular condition, let's say major depressive disorder, and then they're randomized to two groups, and one group gets the medication, whatever it is, and another gets a placebo. So they think that they're taking, or they're given something to take, but it's not the active agent that's being investigated. And in especially depression trials, what you see is that both groups generally respond very well to what they take. And so the active group that's taking the medication that's being taken gets better, and so does the control group.
Wow.
And so typically the only difference is the question is not do people get better when they're in a clinical trial. Many, not everyone, but many people get better. But the question is there enough difference between those that are taking active agent and those that are taking placebo to be shown to be a statistically significant difference so that we can say this medication is effective for this condition.
Hmm.
And in antidepressant trials, this is kind of schematic, but if 10 people take a medication, um, on average with, say, the serotonin specific reuptake inhibitors, and there's certainly debate about these particular trials and what's left out, but speaking schematically, probably 6 to 7 people who are taking an active agent would have sufficient reduction of symptoms to be able to count as a treatment success. But about 4 to 5 or so taking the control, the placebo tablet, would also experience that kind of success. And so you have to give about 5 people an active agent for one person to respond who wouldn't have responded to placebo. So all to say, uh, there's a lot of improvement that happens even when people are taking placebo. And like, well, what accounts for that?
Why? Yeah,
Well,
that's
people
my
are in a
question.
clinical trial.
Why is that?
Yeah. Well, I mean, you're getting regular. You have the expectation that somebody's doing something for me, that there's a possibility
Sure.
of my improving. So there's expectation that goes into that. Also, typically in clinical trials, you're meeting weekly or every couple of weeks with a very friendly, kind person, a research associate or clinician who's asking you questions about your experience and saying how you're doing and wanting to know how you're doing. There's a lot of relationship that happens in clinical trials, but it's never measured because that's not what's being
Right.
supposedly investigated. And so
Interesting.
we have all of this research around like what medications are distinct from placebo, but we're not actually looking at like the relationships that are probably working both in active groups and also in control groups to help people get better. There's a few studies over the last like 30 years that have actually measured the clinical relationship or the therapeutic alliance in psychiatric medication trials. And when those measurements have been done, it turns out that the quality of the relationship between the prescriber and the patient matters for how patients respond to the medication. And so we shouldn't be neglecting the therapeutic alliance. There's a couple of stories that I can tell about that. One interesting study that came out in 2006. There was a study that was done in the 1990s of depression called the Treatment of Depression Collaborative Research Protocol. And these were older medications, but patients either took the antidepressant imipramine or they took placebo. And they also either were they were offered cognitive behavior therapy or interpersonal therapy, which are two kinds of psychotherapy. And I won't talk about the broader study, but there was a retrospective analysis done that showed that patients in this study who took medication or received medication were treated by a number of different like research psychiatrists, and that a group showed that the outcome of how people did in the study was more affected by which psychiatrist you saw in the study than it was by whether you actually received imipramine or not.
Wow. Wow.
So that the third of psychiatrists in the study that had the best outcomes among their research subjects, actually those patients did better with placebo than the patients who saw what might you say the least well performing third of psychiatrists
Wow.
taking the active agent. So who you saw actually mattered potentially as much or more than what you took. That's anecdotal example, but it's one way of making the point that relationships matter. Kind of quality of relationships that patients build with their prescribers really matters.
That's groundbreaking. Like it's groundbreaking in terms of if you're choosing to get medicated or you're at a psych unit, what's the relationship with that
Yeah,
practitioner in that
right.
process of diagnosing and medicating?
Yeah.
That
It's
knowledge is
groundbreaking in the sense that it's not talked about. It's just that there's no incentive especially on the part of pharmaceutical companies
yeah.
to actually measure the therapeutic alliance because that's not what they're marketing. And there's no incentive on the part of health systems to do so either because then we'd have to think a lot more about how do we actually cultivate meaningful therapeutic alliances with patients. And that takes time and investment to be able to do.
Well, and in public systems where some of
Yeah.
us are totally underserved, we don't have enough practitioners, there's not the money
Yeah.
involved. Cancer care has infinitely more resources. So, unless you have money for private care, I can speak
Yeah.
for here in my province, it is grim. You're in and you're out, it's a revolving door. If you're fortunate to be able to pay for private practice, that can happen, but
Yeah.
it is very rare. Our unit was therapeutic. We had those relationships. It was phenomenal. It is now closed. It is now acute. You're in and
Yeah.
you're out. So there's no time for
Yeah.
those therapeutic relationships. Can I tell you a quick
Yeah.
story to align with what you're saying?
Yeah.
I had the kids come to me in my classroom. I was at the end of this unit. So they'd wake up, they were inpatient, they'd come down. And I had this one kid, this is about 3 years ago, so dysregulated, banging the doors and banging the walls and just, I could hear him down the hallway in anger. So he comes in and I'm like, hey, how you doing? Just angry with the world. And his trauma score was a 10 out of 10, by the way. And I said,
Yeah.
hey, have you ever learned how to make a grilled cheese sandwich? He goes, no. So we walk down to the kitchen and I just chat. I'm like, hey, what about mayonnaise? And let's talk about a tomato in there. And all I did was give him attention, nothing on me. And I had the time to do it. This kid, within 5 minutes, just settled. And from then on in, he came in calm and regulated and grounded. And on the way back, I said to the nursing staff, he just needed some TLC. And they're like, yeah, no, the PRN, which is that. What is this? The Latin PRN stands for which?
Basically, it means as needed. That's right.
It
Yeah.
calms
Yeah.
him as needed. They're like, it's kicking in. And I thought, well, it didn't kick in any other day after that. He just needed that. I am here for you and you are worthy and I care about you. And in this unspoken way, everything that's been done to you, you are still worthy, that I'm taking the time with you to make a silly grilled cheese sandwich. So I can imagine for psychiatric care, just that listening and just them feeling that their problems matter must be wildly therapeutic.
Yeah. Attention, a kind of loving attention is what we all need in our lives. We are born needing connection with others. We go through our lives needing to be seen and known by others. As you say, there's an awful lot of kids and adults in our world who have really high burdens of trauma or neglect, who've never really known or haven't known enough what it means to be seen and known and attended to by someone else. And I think we all need that. And if we lack that, we're going to feel that psychologically.
So you say in your book and in your chapter that I read twice that when there is relationship between the psychiatrist and the patient, you choose better medications for that patient, correct? And a better diagnosis. Can you tell me what is it within that relationship that allows for more accuracy on your end as the psychiatrist in both diagnosing and prescribing? Because that all fascinates me.
Yeah. I mean, the word accuracy is tricky because it depends on what's our standard for accuracy. I mean, in principle, with AI platforms, what they are now, there's a way in which you could see that I'm not even sure that a clinician is needed to be able to identify symptoms that people are describing from when they say it and to cluster those symptoms into diagnoses. I mean, that can be a pretty checklist type exercise that I think, and there are structured interviews that basically teach you how to ask questions in very standardized ways to be able to get answers. And I think that those are increasingly going to be automated in the future. So in that sense, I think that a relationship isn't needed for accuracy, if by accuracy we mean simply achieving a DSM diagnosis. Where relationship, I think, is critical is in understanding story, is in providing a space where patients are able to speak about the truth of their lives and the truth of their experience in a way that isn't hidden by shame, in a way that people don't lock into the modes of explanation that they've been taught to describe their experience, whether that's the fact that I have a chemical imbalance or the fact that I have this diagnosis and therefore I'm acting in this particular way, but to be able to help people to think broadly about their life, to be able to come into contact with their own loneliness and their own shame and their own hopes and their own dreams and their own grief. All of that requires more than a computer. It requires more than somebody who's spending 5 or 10 minutes. It requires somebody who actually is able to build a relationship of trust. So I think if by accurate we mean not so much meeting a checklist, but by getting to the truth of the matter or the heart of the matter, relationship continues to be critically important for that.
One of the things that I perceived in all of your writing was when you have relationship, you also have a good understanding of history. So is the
Yeah,
person before me displaying symptoms because they've had trauma, because they were
yeah,
raised in front of the TV for 8 hours a day, or because they authentically have
yes,
ADHD? Because I know that that history piece is enormous for accurate
right.
diagnosis, well, truthful, proper diagnosing that is what is actually happening.
Absolutely. And trying to understand not just someone's like individual history, but also like where they live and what they're
Right.
going through. And I
Mm-hmm.
mean, a lot of my patients, I work again in the US Veterans Affairs system. I mean, if someone is anxious, but they are having trouble paying the bills, or they're living in a motel because the housing prices are so expensive and they can't find a place to live, or they're at risk of eviction, or they're in an abusive relationship, well, that's critical to know. It doesn't show up uh, on standard diagnostic checklists, but it's critical to know about what somebody's going through and what
Right.
somebody's living through.
Yeah.
And I think history also extends not just to the history of a particular person and their own individual stresses, but also to the history of a place. So, like, what does it mean to? I have a, I won't give any identifying details, but I have a patient I'm thinking of who is a farmer in eastern North Carolina,
Mm.
um, that and he's trying to run a small farm as a black man in an area that has a history of where agricultural loans typically go to larger farmers and agribusiness corporations, and where there's also a history of racism in agriculture. And so
Mm.
he has kind of practical concerns like, how do I get the loan that I need to run my farm when I feel like I'm in this culture that's kind of marked by a history of racism? And he's feeling that in subtle ways, and that's affecting his mental health.
Right.
Well, just seeing him as an individual doesn't necessarily get to that. You have to know the story of a place and its people, and I think that's also
Mm.
important for clinicians, psychiatrists, and frankly every other clinician to really be committed to doing well.
That's, yeah, that makes so much sense. Okay, I want to shift to kind of wrap this section up before we do my wrap up questions about just
Yeah,
honing in on medication. So you sent me an article, David Mintz. He's written a few
yeah,
things about
yeah.
diagnosing, or sorry, our dosing, right,
Hmm.
and
Hmm.
diagnosing. And
Hmm.
he talks about antidepressant use and psychiatric
Hmm.
medication. And I was doing a deep dive into research. I won't go into the numbers because of our time, but we know we have increasing medications, dosing
Hmm.
going up.
Hmm.
I've observed very rapid shift to, here are your medications. You're inattentive. You've obviously got ADHD. Go at the
Hmm.
bifenton and, the stimulants.
Hmm.
So my question then, with all of this increased diagnosing, what is your greatest concern in like 30 seconds or less of our medicated world? We can
My
go
greatest
longer than
concern
30
is,
seconds. That might be
yeah.
too hard in 30 seconds.
Well, David Mintz is someone we profile in our book, and I really respect
Mm,
his work on psychodynamic psychopharmacology because he's always asking not just what do medications do, but what do medications mean, and that's critically
mm,
important. And I think that's my biggest concern. It's not that the medications that we typically use now in psychiatry, with some exception, the problem is not that they have like life-altering permanent side effects, because most of the time side effects are transient and temporary. I worry more that we're in a culture that assumes that the answer to what uh, ails us is that there's something broken inside of us that needs to be
mm.
fixed,
Sure.
and that the most efficient way to do that is through medication. And if that's what you're taught to believe, and then you go to a psychiatrist, and the psychiatrist also believes that their job is to apply medication to fix the problem, and then you start taking medication and it doesn't work, then what then? Like
Right.
you might not say, oh, maybe this isn't something that it needs medication. There's a tendency to say, well, we need a different medication, or we need a higher dose of medication, or we need an additional medication. And so people can find themselves on 3 or 5 or 7 or 10 different mental health medications, trying to kind of find ways to tweak symptoms when actually the problem is much broader. And so I think that my concern is not that medications are used, but it's that we expect medications to be the primary
Mm,
solution
sure.
to complex mental health challenges. When, in my view, medications can be very helpful, they can even be life saving, but they're almost always part of a broader strategy,
Sure.
part of a set of solutions, and not the only solution.
I've always talked about it with students as a tool in a toolbox. It's one tool. in your toolbox.
Yes.
But now you
Yeah.
also, I have this note here because I was looking into your writing and just, I believe you spoke about like we cover up the real issues. You've kind of already alluded to that. Like what's really
Yeah.
going on in medication can be a very quick fix, and sometimes it might
Yeah.
be an important quick fix if things are really
Yeah.
critical. But
Yeah.
we're covering up what's actually going on, and we can just stone you up. You don't
Yeah.
remember your time at my psychiatric unit for 3 weeks because you were so diagnosed, or sorry, you were so overdosed on
Yeah.
something.
Yeah. Sometimes. I mean, but I think medications can be used in a way that gives life and that preserves life.
Yeah.
And if they're dosed appropriately and if they're used selectively, I certainly have patients that start taking lithium and their life is just so much better in the sense that they're able to achieve goals and do things. And the same with other medications too. So I think when we see patients that are just so blunted by medication that they can't function, that to me feels like it's a clinical question about like, is that really needed? And I think most of the time when that's the case, it's not.
You've just moved to my next question is what is
Yeah.
the biggest asset of our medicated world? And you already alluded to taking away symptoms,
Yeah.
right? I've seen
Yeah.
kids as a teacher, kids with like authentic ADHD, like it's really ADHD. Holy smokes, it's a game changer. They're now able to
Yeah.
do what they really desperately want to do. So what else
Yeah.
are biggest assets in our medicated
Yeah.
world of medication?
When I talk with residents in psychiatry in the US about thinking about the goals of prescribing, it's symptom reduction is a goal. But again, if you focus on symptom reduction as the only thing that we're doing in mental health, you kind of lose what I think matters to a lot of people. So I think about three concepts. One is agency. And by agency, I mean the capacity of a person to be the originator, the seat of their action. So am I able to act for goals and purposes in the world? And to what extent is medication helping me to do that or not? Another would be relationship. Like, we all need relationship as human beings. We thrive in relationship. We become who we are in relationship. So is medication taking actually making it possible for me to engage in a healthy and constructive way with others? Or is it taking away from that? So if medication is keeping me from the kinds of relationships that I need to do with others, then that can be a problem. But if it's helping that can be a good. And then the third is more diffuse, but it's story. So how do we think ourselves not as like machines that are carriers of symptoms, but as people, as creatures who live in and with stories of our families and communities and ourselves, and how does medication fit into the story of who we are? And that kind of narrative wholeness is important to me also. So I think the promise of medication is that like many of the medications that we use can be really helpful for helping to restore and to safeguard agency, for helping to allow people to maintain healthy relationships, to find ways of making sense of their lives that leads them to a better future. And I think medications can play an important role in all that. So I'm not against medication, but I am against a conception of psychiatry that sees medication as like the most effective treatment in mental health care period, or psychiatrists as those that are primarily the medication professionals that should be focused on medication and not other forms of treatment. Because frankly, for most mental health problems, medications can be helpful, but it's almost never the case that medications are the single solution. You almost
Right.
always need a broader set of responses.
Before we wrap it up, one of the things that I've always, and even as a mom, struggled with and discussed
Yeah,
with my psychiatric students is that very fine balance of the benefits that I get from this. And I completely agree with you. I've seen phenomenal outcomes of medication, but I've
yeah,
also seen huge side effects. So can
yeah,
you quickly speak to that idea of the benefits outweighing what's damaging or detrimental? Because I've been
yeah,
told like there's a balance there and what outweighs what, and especially I think for parents choosing to medicate young children or
yeah.
adults where there's huge side effects, that is a
And
tricky
side effects are
decision.
real, and we have to acknowledge that. And different psychiatric medications can cause, emotional blunting. They can cause transient sexual side effects. They can sometimes cause movement problems. There's lots of things that can be the case. Certain medications can increase the risk of metabolic syndrome and diabetes. So we have to be just aware of all of that. And I think just speaking truthfully is really important. So if people are experiencing side effects or if they think they are, then being honest about that with their clinicians and not hiding that, just saying, hey, I'm experiencing this and it's troubling to me. And what do you think about this? I also think that psychiatrists and other clinicians need to be honest with their patients about about the possibility of side effects and also just be open about them. And so I think there's a tendency sometimes to think, well, this patient really needs to be on this medication and they're complaining of side effects. So I'm just going to kind of downplay that in hopes that they'll kind of ignore it and keep taking the medication. And more often that doesn't work because people stop taking the medication because they recognize they're having adverse effects without telling their prescriber. And then there's a loss of trust in their relationship. And that isn't a pathway towards success. I think just telling the truth, being honest, being clear, and in many cases, side effects are manageable through either dose adjustment or through substituting a different medication in the same class. But telling the truth is really important. And for clinicians to be able to hear the truth is really important.
I always do 3 wrap-up questions to take us to the very start. And my goal has been for people that are choosing medication or even like working with psychiatry and dealing with mental health disorders of what's that decision to medicate and what I'm doing in the process. So here's question number 1. If I am debating taking medication for any mental health challenge disorder, can you give me the top 3 things I should consider?
One is safety. So if someone is having any thoughts of suicide or any other concerns about their safety or the safety of someone else, that's an immediate need to get help. In the US, we have a national mental health crisis line, 988, where somebody is available to consult in any moment. And so I think that's important. The second is to seek help. If anyone is in the position of wondering if they should be on a medication, that they may or may not need to be on a medication, but they do need to not keep that to themselves. They need to be able to seek the counsel of others, to get someone else to ask questions, to help them think through. And then I think that kind of openness to think like what might be the possibilities of medication for me. But I think also what are the goals that I have in the taking of this medication, and not thinking that all I need is a medication.
Warren, one of the things I had discussions with over and over again with my students on that unit was this notion that they did not feel that they were worthy of asking, of reaching out, of seeking that help and knowing that they're worth fighting for. And I had kids from our unit saying, I learned here that I am worthy. My problems matter. So if I can add that, just that you are worthy of being taken care of and bothering, quote unquote, somebody to get the help, because I saw that so often with people that struggle.
Thank you. And I think that's really important. I think everybody needs to know that they matter, that they have worth that's not dependent on their capacities or their production or anything, the kinds of things that we value in our society. It's critically important.
Okay, question number 2. What is the mantra that every prescribing psychiatrist and diagnosing psychiatrist should have when encountering a patient? What's their mantra? What should, in a perfect world?
How can I see this patient not as a machine that needs to be fixed, but as a wayfarer who needs accompaniment?
Love it.
And what's needed right now for the journey?
Oh, that is so good, Warren. This is why I emailed you a year and a half ago. That is it. I love it. That is it. Okay,
that question, what's needed right now for the journey, goes a long way. Because what's needed might be a medication.
Sure.
But it also might be to get out of an abusive relationship, or it might be a supportive community, or it might be a lot of different things.
No, for sure. Okay, so last question is for somebody who is struggling and they're maybe not getting help and they're not reaching out. Where is that tipping point that they know, like that defining moment that I have to do more than just sit here and endure this?
One is to say that if you're struggling and you're wondering, should I get help? You've already passed to the point where you deserve help.
Right.
Like you are already experiencing enough to absolutely deserve the help and support of others. So I'd say get that help. Don't keep wondering about it. Get that help and reach out to someone trusted around you to figure out who you can speak with and how you can access the right kind of help and support and care inside or outside of the healthcare system. And that can look different ways for different needs. And I think the second message is, and this is to what we just said, I believe that every human being has essential, irrevocable worth and belovedness. And so I think there's no one in this world who doesn't deserve care, or who doesn't deserve the chance to flourish, or who in some ways, should be forgotten. Like, no one should be forgotten, and no one should be left behind. And if you feel like, if you're wondering, like, do I deserve to, like, reach out and get the help of others? Yes, you do deserve it, because you're a human being.
Yeah.
And you have worth and value, and that's deeply important for who you are.
I think that response is so key. Of just that I'm even asking that question, I've already answered that. Just, asking about, like, do
right.
I need to go further? Warren Kinghorn,
That's right.
Your book. I'll put this in the notes. I just love the idea of a relational guide to pharmacology.
Mm-hmm.
So thank you so much for your time, and thank you for your words. I think it is so needed in this day and age, with what we are seeing of high levels of medication and high levels of mental health disorders.
Thank you. And I also want to credit my co-author, Abraham Nussbaum, who's also a psychiatrist and is a colleague in all of this. And if he were here, I think he'd be echoing some of the same themes.
Thank you, Warren. Thanks for listening. Now, you can subscribe to this channel if you want to get more content about learning how we find authentic connections, and click like on that little link below. But more, share this with somebody who needs to build more of their own wellness and foster relationships with other people. I'll see you next time.